Hi, this is Herb Kressel, and welcome to the November Radiology Podcast. This month we have a very interesting and somewhat unusual potpourri of articles to discuss. First, we'll begin with a panel discussion about an article which was authored by Dr. Hannah Zafar of the University of Pennsylvania, who with her colleagues did a qualitative study on factors that influence primary care physicians' follow-up of incidental findings. Her title was intriguing. It's called Chasing a Ghost, Factors Influencing Primary Care Physicians' Follow-up of Incidental Findings. And joining me and Dr. Zafar are Dr. Stephen Flyer, a primary care physician in Newton, Massachusetts, and Dr. Stephen Boswell, who is the CEO of the Fenway Community Health Center. I think you'll find this discussion quite illuminating and well worth your time. Next, I'll be speaking with Drs. Pavel Rodriguez and Timothy Duong of the University of Texas Science Center at San Antonio. They and their co-authors did a multimodal randomized fMRI study of the effects of methylene blue in the human brain. And you might be asking, what does methylene blue do in the human brain? Well, it appears to improve memory and increase attention. So for those of you who are falling asleep, you'll find this worth listening to. Next, I'll be speaking with Dr. Natalia Maximova, with her colleagues in Trieste at the Institute for Maternal and Child Health in Trieste, have reported on hepatic gadolinium deposition after contrast-enhanced MR imaging in pediatric patients who have undergone hematopoietic stem cell transplants. And fascinatingly, they have some data on the reversibility of the deposition using chelation therapy. I think you'll find both the articles and the discussions quite stimulating, and we thank you for your interest and look forward to hearing from you as well. Hi, Herb Kressel, editor of Radiology, and today we have a very special panel discussing a paper that will be appearing in the November issue of Radiology. And the paper is written by Dr. Hannah Zafar and her colleagues at the University of Pennsylvania, and it's entitled Chasing a Ghost, Factors Influencing Primary Care Physicians' Follow-Up of Incidental Findings. And joining me in speaking with Dr. Zafar is Dr. Stephen Flyer, Assistant Professor of Medicine at Harvard Medical School and a Principal and Personal Physicians Medical Group in Newton. Full disclosure, Dr. Flyer is my personal physician. And joining us as well is Dr. Stephen Boswell, Assistant Professor of Medicine at Harvard Medical School and CEO of Fenway Community Health Center, which is a fantastic community resource in Boston. So thank you all for joining us. Welcome.
Thank you.
Pleasure. Let's start with you, Dr. Zafar. Why did you undertake this study?
Sure. So, incidental findings are prevalent, I think, in across radiology, across subspecialties within radiology. And despite the frequency with which we detect these findings, there is an inconsistency, I think, among us as radiologists with regards to how we communicate these findings. We also have witnessed inconsistency in how patients are followed up when we make recommendations for follow-up. And so the impetus for this study really came from a curiosity to try to understand that after we sign off on our reports, there's a big black box from our end as radiologists that involves the receipt of the report by the provider, a dialogue with the patient, and some sort of shared decision-making on how to pursue the incidental finding that we follow up. And I wanted to learn myself and also share with the radiology community what is happening in that black box.
I see. Now, one of the more interesting aspects of this study, particularly for a journal like Radiology, is that you used a qualitative research method.
Yes.
Which is unusual for our journal these days. Why did you choose this method rather than, having a survey and have it be more quantitative?
Sure. I think as scientists, we are certainly driven by quantitative research and the need to measure things in percentages and proportions. But before undertaking that, I thought there was a need for us to use a qualitative approach in order to understand what are providers telling us about the factors that are important to them when they want to communicate and manage incidental findings. So rather than imposing my bias as a radiologist as to what would be plausible from my end, I wanted to be informed by them. Certainly the purpose of doing a qualitative type of a study like this is so that you can use the results to then go on and build, as you said, more of a quantitative survey type of a research endeavor.
And we're going to get into some of this a bit later, but how would you describe the key findings? What did you find that sort of you were most surprised by?
Sure. One of the big take-homes for us from this paper was the sheer frustration that was expressed by primary care providers with regards to understanding or feeling compelled, I should say, rather, to follow up findings that they suspected to be overwhelmingly clinically benign, and yet for a variety of different reasons which they cited, they compelled is a good word for it. They really felt forced to follow up these findings, whether that be for concern for medical legal practice, whether it was because they anecdotally had one patient in their practice who had developed cancer with some sort of a similar finding. There were many reasons cited, but one of the terms I remember specifically that a provider used was quagmire. They felt that they were drowning in a quagmire of incidental findings and that their hand was being forced.
Well, I must say, I found the quotes particularly meaningful. When I first started to read the paper, I have to say I was a bit skeptical because it was so non-quantitative. But when I read it, it was like I heard voices in my ear echoing my past encounters. So I'd like to turn now to our other panelists. Dr. Boswell, what sort of concepts, ideas, and quotes, what were the things that stuck in your mind as you looked at this paper and rang true?
Well, I think as a primary care physician myself, I certainly sympathized with many of the statements that were made in the study. I'm always struck by the fact that this is really a Bayesian kind of issue in many ways. It's very hard to separate clinical findings from a diagnostic test from the context in which that test was performed. So in most situations, it's left to the ordering and often the primary care clinician to make that additional information available in terms of thinking about how to respond to these kinds of issues. Mm-hmm. So, a patient who comes in having just traveled to Africa, let's say, who has, let's say traveled there a year ago, now comes in with a new spot on a chest x-ray or a CT scan. The follow-up for that is potentially different than it would be for an 18-year-old otherwise healthy person who resides here in the New England, who comes in and you have an incidental finding of a nodule. So incorporating all of those things together, it seems to me, is the real challenge here in terms of knowing what to do.
Dr. Flyer, what things kind of rang true or
the overall sense of frustration was what rang true to me. And I think the striking thing to me is the term incidental kind of rings of something irrelevant or just, found on the side. And just because something is incidental doesn't mean it's unimportant. And that's the really hard thing, the terminology. I personally find the greatest difficulty in dealing with incidental findings when I'm not the ordering physician. And I think it sort of plops on your desk in a way that sometimes comes without a context. And, an example might be a coronary CT or a CTA of the chest that's done that shows something in the dome of the liver. And the cardiologist is really not interested in that at all and isn't even looking at that.
Exactly.
And yet it would show up as a potentially relevant finding. I'm struck in part by the fact that there are times when I have found something early because of an incidental finding, and there are times where I've gotten into a blind loop because of an incidental finding. And the same way that we often make decisions clinically based upon the most recent case of what we had, you can either think of an incidental finding as an unexpected godsend that you find something early, or as opening the rabbit hole into which you'll fall. I think those are the big issues that I see as a primary care.
I mean, renal cancers. When I was in training in the Pleistocene era, before there was a lot of CT and MR, they were being found, symptomatic, large masses and this and that. And the whole way we look at this and the whole way we approach it is based on incidental findings. These cancers are, I think the majority of them are now found as an incidental finding. And as you said, they're not incidental in the sense of not being important.
Right. I think there are types of incidental findings where there are some available algorithms, incidental adrenal findings, incidental thyroid findings. I think it's when they're outside of those kind of well-structured areas that the complexity starts to rise. And the fact, sorry, hope I'm not going too long here, the loop of, one radiologist suggesting, do a nuclear study or do an MR for follow-up, depending on what the modality is. You sometimes see these things go full circle back to the original modality.
Yes. Now, the types of patients in your two practices are different in terms of income and lifestyle. And do you think this affects your approach to dealing with incidental findings? Let's start with Dr. Boswell in this one.
Absolutely. I think that's the point I was trying to make earlier, was that the prior probability of a finding in a patient absolutely affects how you interpret a diagnostic test. So,
but what I was thinking about is let's think about the economics. Let's say this person has out-of-pocket costs, and does that affect the calculus of what level of risk you're willing to take in following it up or not following it up?
I think there's always an issue that gets raised around this, especially in the population that we care for, in part because the out-of-pocket costs can be quite substantial and meaningful for those individuals. I think the shared decision-making is a critical part of this. If you explain, what you know based on the patient's situation and the results of the test, you can together arrive at a decision in terms of the way to appropriately follow up an incidental finding. And that may be slightly different from one patient to another as a consequence of that decision.
Even within your practice.
Absolutely.
Dr. Flyer, how about you?
Obviously finances play a role in everyone's choices, even those who are not indigent. But I think that the conversation that I have more often is about levels of uncertainty and how comfortable people are with uncertainty and how much data is required to move the needle on uncertainty towards an acceptable level, which is, I think, part of the calculus here for each and every patient.
Very interesting thing. So that you feel is best handled on a discussion, sort of shared responsibility there.
One-on-one and shared conversation.
Dr. Zafar, do these two primary care docs sound like you could have interviewed them? Do they sound like they would fit into your study?
Absolutely, absolutely. I mean, so one of the things that's come up here is that there isn't really a one-size-fits-all kind of an approach for how primary care providers choose to communicate, and that is, I think, a word worth dwelling on a little bit, because the question is, or the crux of the matter is that they don't always communicate the finding to patients. That was something that came up in our paper as well. But so there's heterogeneity in how or whether you choose to communicate the finding, and then also how you would go about recommending or guiding the patient into what the options are that make sense for them in their clinical context.
So in that context, does it affect the discussion that you'd have with one of your patients if they are one of these people that have read the report and showed up with sort of a sheaf of internet downloads to stimulate the discussion, or do you sort of try to weigh the evidence sort of as it is in your understanding of the patient? Dr. Flyer, you're always downloading stuff.
I am. And in fact, we often have patients who are armed with the information, have seen it almost simultaneously with our seeing it. That's for studies that I have ordered.
Yeah.
And I'm much more comfortable with that than in dealing with studies that I haven't ordered, whether it's emergency department or other specialties, for example. But the same way that we will have to explain to a patient who's looking at a printout of their lab data, what does it mean to have an abnormal MCHC? Does that really mean anything, even though it shows up with an asterisk or in red? There are abnormalities that are relevant and abnormalities that are irrelevant, and those that we can't be sure until we sort of see how things will move with time.
Mm-hmm. Well, how does this affect your kind of discussions, whether the patient's read the report or not?
I think it's part of the overall discussion that you have. I mean, some patients are very hypervigilant and very engaged in their care, and the conversation to arrive at a joint decision about how to manage a situation like this can be fairly complex and protracted. But I think you have to spend the time once the issue has been raised with each patient.
So
can I ask the author?
Yeah.
And I apologize if I didn't notice this in any of the comments, but how many people read the substance of the report in detail versus read the conclusions in detail?
Sure. So we didn't actually touch on that in this paper. It's an excellent question. Again, this is a recurring theme with the paper. There's a lot of heterogeneity. There were some folks who, just as you are well aware, due to time pressures, would go straight to the impression at the bottom of the report. Other people, if they felt that other providers, I should say, if they felt that the impression didn't address the actual reason that they had ordered the report or felt that there was insufficient detail in the impression, would then go up into the body of the report. So there's two different ends of the spectrum. I should also add that there were some providers who said that they would even open up the images and look at the images themselves, potentially if they maybe didn't quite trust a finding or just wanted to see it with their own eyes, or they needed to show it to the patient in the office to illustrate what the abnormality was and what it looked like.
Good. Now, our two primary care doctors and I all practice in the state of Massachusetts, and Dr. Zafar is at the University of Pennsylvania, but interestingly, just a few weeks ago, the Commonwealth of Massachusetts Board of Registration in Medicine issued an advisory on incidental findings. And I found the advisory very timely, but a little bit strange in that it was cautionary for failing to act on important incidental findings, and then cautionary about acting on insignificant incidental findings. And the problem is that we can't always tell which is which. That stimulated, I think, a good deal of pushback from the medical community at large in the state that got into the press. And the Board of Medicine sort of backed off slightly, and they said, well, we just want to bring this to your attention. We're not really making a hard or fast that, some groups are doing it correct or not. So I guess the question that I have to our primary care doctors is, to what extent do the kind of performance incentives, the quality of care incentives by the payers and the like, do they figure in affecting how we act in these situations? The board in their advisory, they specifically said, that the primary care doctor should be aware of the added risks of ordering a CT that isn't necessarily indicated.
Well, I think ordering any test that isn't indicated is never a good idea, whether it's imaging or laboratory or any other form of test.
Well, the problem here is that you're making the decision if it's indicated ex post facto after it's not a positive result.
Yeah, I didn't find the board's advisory terribly helpful in any way. It didn't really focus thinking in any way, other than to sort of just put a spotlight on the fact that incidental can mean irrelevant or can mean quite the opposite.
I'd say that.
And that the term should be probably altered to represent unexpected findings of clinical relevance or unexpected findings of probable irrelevance.
Interesting. Dr. Boswell?
Well, I think we approach these kinds of decisions, which are rarely ever, in my view, black and white. They often are very gray. The way medicine typically approaches these kinds of issues is with cost effectiveness or cost benefit analysis. But each situation is so remarkably different that it's hard for that type of analysis to really inform this process at all. One of the big concerns I have as someone who runs a fairly large organization is the variability across all of our providers.
Yeah.
The one thing that I would want to see happen is that all providers take the same information and arrive at the same decision about how to approach it, or a very similar type decision as to how to approach it, at least indicating that what would be hard to explain, I think, is large amounts of variation in how clinicians are approaching the same finding in an imaging study.
Well, Dr. Zafar, this is really at the heart of your paper. So what's your sense of the lay of the land? You interviewed dozens of primary care doctors, if I recall, and it was a very heterogeneous approach to almost every aspect of this problem.
That's exactly right, Dr. Kressel. There were both objective and subjective factors. So certainly patient age and comorbidity, those are more objective, but then there are subjective factors that come into play, some of which have been alluded to today. So the personal rapport that you may have with the patient, whether it's the first time you're meeting them or if this is somebody who knows and trusts you. The patient's anxiety level, that was something that was cited as a factor that could in fact supersede guidelines, that if you had a patient who was very anxious, that regardless of what the guidelines may tell you, you would override them for that patient's well-being. Health literacy is one that came up fairly frequently, and then of course some of the logistical issues as well that we've talked about. And that's just on the patient side. Then there's the provider side, which have to do with your follow-up style or philosophy. Are you somebody who regardless of who the patient is coming into your office, you're going to say that for every single patient I have who has this finding, I'm going to follow it up exactly the same way. And so when you put all those factors together, you're going to get a real, mixed soup of how people will respond to.
You have any suggestions for Dr. Boswell? I'm sure he manages dozens of physicians who think they're right in everything that they do, and I'm sure there's the same variability that you're describing is throughout the different sites of the Fenway Community Health Center.
Well, far be it for me to advise him how to run his practice. I'm sure he does that. But I think, Dr. Kressel, one thing that's really lacking in this area are very good evidence-based guidelines on what we should be doing with some of these common findings. So for some types of findings, we do have good literature out there with regards to, if you have a mass that clearly looks like a simple cyst in the kidney, just leave it alone. Don't do any further follow-up. If, on the other hand, you have a mass that's a new indeterminate mass on a CT scan, that is something that should prompt further workup. As everyone in the group has just alluded to, the frequency of renal cell cancer that's detected incidentally on imaging is not trivial. So, the issue is, I think we need more evidence-based guidelines. We're not quite there yet. One of the things, I'm trying to answer your question, but I'm also curious to know what my colleagues have to say about this. One of the recurring themes that I was surprised about in the paper was the desire of primary care providers to have recommendations for follow-up put consistently within radiology reports. I think a lot of radiologists feel uncomfortable doing that. We certainly don't want to force our colleagues' hands. But what I was hearing on the other end of it from the primary care providers is that if you don't give us those recommendations for follow-up, we don't necessarily know what to do. They gave two examples. It could be a finding that I see very commonly in my practice, but the patient is coming to me in a particular clinical situation. So like a hemangioma, but then a provider said, well, it was a hemangioma picked up in a pregnant patient. I don't know if there's a relationship there that I should be ignoring. And then there's the second issue, which is that providers may see a finding that they're not familiar with, and they just don't know how to follow it up. And they may not have time to get on the phone and call the radiologist or get on the phone and call the gastroenterologist, the subspecialist. And so in that vacuum, they may not do anything at all because they just don't know what to do. And so there may be a situation where, in fact, follow-up is needed. The radiologist felt shy, perhaps, about putting that down on a piece of paper, and then the patient is not getting the correct follow-up in the absence of spelling it out, which is, I think, equally detrimental as a radiologist potentially recommending follow-up for a lesion that doesn't really need follow-up.
Right. So this brings us really to the heart of what we're doing here today. And unfortunately, Dr. Bill Thorwarth, who wrote the editorial that accompanies your article, wasn't able to join us today. But the point that the college is making, that radiologists have to be much more actively involved in as part of the caregiving team. So the real question comes up is, for both Dr. Boswell and Flyer, how can radiologists be most effective in the context of reporting and recommendations? And sort of as a sub-theme, this notion of there are areas, and I've seen in the ACR white paper on the incidental findings of pancreatic cysts and the like, where they are giving percentages, the percent likelihood of a malignancy. But the question is, in some senses, if you give someone, this patient has a 1% chance or whatever, is it forcing someone's hand too much? Is it helpful, or is it sort of constricting? So that's sort of the question we should perhaps sum up on. Dr. Flyer?
Well,
what's best for you? I know if I give you reports, they're always good, but aside from that.
Well, I think it varies with the specifics of the report. If I'm ordering a report for a specific reason and something incidental is found outside of what I'm looking for, I understand the context. I think it's a lot harder when it's kind of falling out of emergency or unrelated specialty care. And I think those are harder. I think that the term clinical correlation advised should probably be banished from the lexicon because no one knows what that means.
We had an editorial about that already. You're a couple of years late.
And I assume that the agreement was that it shouldn't be used.
No, it should not be used for both.
But it still shows up. It still does.
I know.
And I think that in those areas, I think we should try to move to more predictive guidelines. I think the Fleischner guidelines, for example, for following lung nodules is extraordinarily helpful to primary care physicians because it gives a structure both in the context of expected malignancy, risks of metastatic disease versus normal risk of metastatic disease or no risk of metastatic disease. I think those kinds of guidelines are very helpful. And I think the more specific, the better when it comes to radiologic recommendations. And I think a recommendation to speak with the physician who does the reading would be extremely helpful. Back in the good old days, those calls used to come all the time.
Well, I think that was, if Bill Farworth was here, that would be the heart of what he would like to add. Dr. Boswell, well, what are your thoughts? What can we say to help Dr. Zafar?
Well, I do agree with Dr. Flyer that having ready access to the clinician that's actually doing the reading, I think, could be tremendously helpful in interpreting some types of incidental findings on any number of imaging studies. But I think, again, it's hard. It's very hard, in my view, to write specific, tremendously helpful guidelines that don't encompass a fair amount of the prior probability of a person who's sitting in front of you.
Right.
That person's traveled, that person's history of previous malignancies, all sorts of things like that may not be included in the original order become critical parts of that probability that you're trying to assess. So
right. What we're seeing with those is that, you can have a probability based on an imaging, but then they layer in basically a normogram where you get these scales where for different demographics or travel or whatever, you sort of add points, and then you ultimately get a more individualized risk assessment.
Yeah, or you can even have something kind of the opposite of what we've been talking about here. When years ago, when I ran the HIV clinical service at Mass General Hospital, I used to send chest X-rays for my patients, and I would deliberately not tell the radiologist in the history that the patient was a gay male or anything that would affect their prior probability, because every single chest film, this is a bit of an exaggeration, but not far, would come back with a reading of possible, pneumocystis pneumonia. These interstitial markings look a little prominent. And so it goes both ways, that if we're not careful and we don't communicate our concerns with the person reading the film and the person who has to then take that information and make a clinical decision about management, if there's not communication happening there, a lot of things can get missed in both directions.
I think that's actually a very important, I think it's kind of an interesting direction that this is taken, in that communication is really at the heart of this. And I think from the college's point of view, they really see that the radiologists have to step up and be more engaged and available in that. Dr. Zafar, any last thoughts from you?
No, I mean, this has been a great discussion. I really enjoyed I enjoyed putting together the paper in great part because of the quotes, which you referred to as well, Dr. Kressel. I think it's so important for radiologists to try to start, at least, to wrap our hands around, our arms around this issue, because so much of, we are writing the report for the provider and ultimately for the patient. And it's important for us to try to appreciate some of the nuances of what goes on in these interactions based on our report and what we can do to help providers and patients.
Very good. So I want to thank all of our guests, Dr. Flyer, Dr. Boswell, and Dr. Zafar. Thank you for the paper, Dr. Zafar, and thank you for the thoughtful and stimulating discussion.
Thank you, Mark.
Thanks.
Bye-bye.
Bye.
Hi, this is Dr. Herb Kressel, editor of Radiology, and welcome to the November Radiology podcast. Today I'm joined by Drs. Pavel Rodriguez and Timothy Dong of the University of Texas at San Antonio. Dr. Dong is a professor of ophthalmology and radiology at UT San Antonio, and Dr. Pavel Rodriguez is a senior resident at UT San Antonio who is in a fascinating program combining a residency in radiology with a PhD. Welcome, Dr. Duong and Rodriguez. Thanks for joining us.
Thank you for inviting us.
Thank you.
Delighted to be here.
Sure. So your paper is entitled Multimodal Randomized fMRI Study of the Effects of Methylene Blue in the Human Brain. And I must say, when I read the title, it sort of took me aback. I didn't understand how methylene blue was getting into the human brain except as a vital dye. So, Dr. Duong, why did you undertake the study? What's the background here? Is there a relationship between methylene blue and cognitive function?
Right. So methylene blue has been used extensively in the clinical setting for emergency purposes, as well as for methemoglobinemia. And there are quite a few studies on its effects on oxidative stress and among other things. But there are recent studies that look into the cognitive function using using behavioral tests that show cognitive improvement in animal model as well as in human. So the reason why we undertake this study is that we want to see what is happening in the brain. What's the neural correlates of the effect of methylene blue on memory and cognitive function? So
your study was looking specifically at the physiology. If there is an effect on brain function, how does it manifest on fMRI? Is that correct?
That's correct, yes.
Okay. And so, Dr. Duong, what did you do? What was the basic research design?
So the experiment, the study that we undertook was that we used functional MRI and behavioral tests on a group of normal healthy volunteers. And the study is a double-blind, randomized, placebo-controlled, where we have just the volunteers, the participants, take either placebo or the methylene blue, and an fMRI study with cognitive and memory readouts was performed before methylene blue and after methylene blue. And we want to see the improvement associated, or if any, associated with the drug.
And how long after the drug was taken did you do the fMRI?
Well, about an hour.
Okay.
After the drug. And we also have behavioral readout 2 weeks later.
Oh, okay.
Right. So.
And Dr. Rodriguez, if I remember correctly, you had a group of around 30 and you divided them in half. How did you determine the sample size for this, since it's not that much is known about it?
Yeah, so that was a pretty difficult task. Initially, when there was very little information about methylene blue in humans, unlike a lot of compounds out there. And so in order for us to, when we came to that question of sample size, we had to sit back and basically look at a lot of the animal data. Fortunately, we have animal data going back to the 1970s, different psychology tasks that are performed on rodents, on rats. And based on that data, on those different experiments and consultation with, we are working also with an expert from the University of Texas, Dr. Francisco Gonzalez Lima, in collaboration with him, he's a pharmacologist and neuroscientist. We came to the conclusion that we wanted to start definitely at a low dose, because we know that methylene blue has opposite effects at lower doses versus higher doses. At lower doses, it enables a positive effect through its action on the mitochondria, but at higher doses has an opposite effect. So based on this data, we concluded that a 4 milligram per kilo dose was kind of the right dose for a start. That ended up being for a 70 kilogram person, that averages out to around 280 milligrams. So that's what we administered to subjects. And to add to what Dr. Duan was saying, the subjects went inside the MRI scanner, completed the series of tasks that were set up. Then they came out of the scanner, and we had them wait 1 hour. And that was actually that 1 hour was based on pharmacology data in humans from Europe, where subjects were given a pill and they were asked to wait for 1 hour. And that was the amount of time that was required for the drug to become available in the venous circulation. And so there was a logic to that 1 hour.
What about the decision to have 15 subjects in each group? How was that made?
So for fMRI studies, it's a very statistically powerful technology, because the idea is that you're taking hundreds of thousands of data points, so that increases your power dramatically. Yes, you can have more false positives, but because of the statistically powerful possibility from the MRI technology, it's not unusual for you to have 15 to 20 subjects for fMRI studies per group. So that's one convenience from this technology, that you don't require 100 subjects per group.
If I may add to that, the basic of the design is based on our experience in fMRI design, where we know we have multiple fMRI readout, multiple tasks being performed in the same subject. So consequently, based on our experience, N of 15 or so is very adequate for this kind of task.
And I understood that at least during the manuscript review, there was people were asking about why not do a crossover design where the placebo group then would receive the agent and the group that had the agent would get the placebo. Did you think about doing that?
Yes, we thought about doing that, and there's a lot of work especially from the caffeine literature folks that have done that kind of work using crossover design. In this case, and I do go into this in the supplementals of the paper. So in our case, we thought about this, and we kind of came to the conclusion that it was best to do this double-blinded and have two groups and go through this more elaborate design, because we would not know how long the effect of So this is the first study of methylene blue in humans, and so we did not know how long the cognitive effect will last. So if I were to give you a drug, and we would not know when will be the correct time to scan the subject that had it before, as opposed to the people that had the placebo first. So that window we would not know. And then the other thing is that you have to wrestle with the fact that everyone that takes methylene blue has colored urine. So all the subjects in the methylene blue group end up voiding blue. It's a harmless effect that goes away after the medication comes out of the body. But we did not figure out a way to control for that effect, unfortunately.
Right. And so they would blind themselves when they went to the bathroom. So
exactly. And they were blinded to not go. They were not allowed to void while they were at the site. So we told them to void before, and they would not be allowed to void during that 1 hour after they took the drug.
Right.
But it's a little bit more challenging, because of those two components.
Right. So, Dr. Rodriguez, what did you find? What were your key findings? What happened on fMRI?
Yeah, so we had them do is we set up a sustained attention task, the psychomotor vigilance task, which it measures a form of sustained attention is a form of alertness. So we did notice that in the subjects that took the methylene blue, there was a positive drug times time interaction in the parts of the sustained attention network, the bilateral insular cortex. And so we didn't notice an increase in fMRI signal compared to the subject that took the placebo in the methylene blue group. And then in the task we had the subjects do is a working memory task. They call the delay match to sample task. And that's working memory is a form of short-term memory. And then we also discovered in those subjects that took the methylene blue, there was an increase in fMRI, a Bowl signal in the dorsolateral prefrontal cortex, in the parietal areas, the cerebellum. And we actually split up when we modeled the different tasks, we split up the different components, and there were encoding components, maintenance components, and the encoding and the maintenance components, we did see increase in areas that are important for these neural networks that mediate encoding in working memory and maintenance in working memory.
So you showed that fMRI activity increased in the suspected areas where you would expect it, but what about task performance?
That's
that they were just kind of spinning their mitochondria faster, but they weren't functionally better.
Yes, and that's actually even, to me, it's even more fascinating because we want to improve performance. And in the alertness task, the sustained attention task, we did not see a difference in the reaction time of the subjects. Basically, the subjects press a button whenever they see a cross change color. And so we did not see a change in that. We only saw increase in fMRI signal for that particular task. And that might be because the effect size may be really small, and instead of doing 15, we may need to do 50,
right.
15 instead of, we may need to do 15 instead of 15 subjects. However, in the working memory task, and this is a task where going back to the rodents, this had been studied extensively in rodents, especially the working memory. Not the sustained attention task, that was kind of this is the first time being tested. It had not been tested in rodents before, but we did see an increase. The subjects that took the methylene blue had there was a 7% increase in correct number of responses relative to the placebo group. So that was statistically significant. There was no change in the placebo group.
I see. So just to, if I understood you correctly, Dr. Rodriguez, you said that in addition to doing the 1 hour, you scanned them again after 1 week. Is that correct?
No, that's not incorrect. We had them. They were scanned 1 hour after they took the medication, and that was the last time. We had them. What we did is we surveyed them 1 week later via psychology surveys, and we tried to see whether there was a delayed memory enhancement.
Okay. They had any feeling about that?
We did not see an effect.
You don't have any idea at this point how long the effect would last?
So unfortunately, we do not know exactly how long the effect will last, given that it was the first study. But we are working on that particular question to see whether it's an immediate effect, whether there's some latency to the effect. We are definitely working on other more clinically relevant studies.
And tell me, Dr. Duong, this sounds like you've put your finger on something that's a very hot area. So how do you envision the research going forward? You must have a lot of different questions you'd like to answer.
Yes, there are quite a few follow-up studies that we are planning. The main piece is that this is, as you mentioned, methylene blue is very safe, and it had been used clinically for many years. So in principle, one can take a pill and daily and potentially improve cognitive functions or memory, etc. So, but the research is still early in the stage. We do not know what is lasting effect and what's the how often should one takes it, etc. But we're very excited about the possibility that methylene blue can be used to enhance memory and cognitive function, as well as for treating patients who have dementia or Alzheimer's disease.
So you're not sure if you could imagine this as something that college students would take when they're studying an all-nighter to help them prepare for the next day's exam, or something that you would take when you're a baby boomer contemplating retirement and want to remember what you did yesterday?
That's a very intriguing idea. Again, the study is still the idea is still early in the stage, but I would imagine it's possible that one can take a pill before the college exam, such as taking a caffeine. But again, this is still far in the future, and we are looking into that. But it's very exciting given the fact that methylene blue is already pretty safe and is used clinically, and it appears to have cognitive effects by both fMRI readouts as well as behavioral readouts.
And one thing to add is if you are a college student and you decide to take methylene blue, make sure you get the USP grade form of methylene blue, which is the pharmacology grade, United States Pharmacopoeia grade, because the one that you can find for your fish pond, it's not safe. It has a lot of contaminants. So
don't take the fish pond.
That one. And I wanted to add something for future directions. What Dr. Duan was saying, this is a pretty fascinating area. Our initial study in young subjects was basically a proof of concept study. And we've taken the results from the study and moved it immediately into a clinically relevant study. Right now, we're conducting another phase 2 clinical trial where we're testing methylene blue longitudinally in a 12-week trial in subjects that have mild cognitive impairment and subjects that are healthy controls, elderly controls. So these are more clinically relevant populations that would definitely benefit greatly from this medication.
If I may add also on top of that is that the study that Dr. Rodriguez just mentioned is that it is not a single dose. It is a daily dose up to 2 weeks. And we have multiple readout. Yeah. 12 weeks?
12 weeks.
Oh, up to 12 weeks. So, and that had multiple fMRI readout, behavior readout at different interval. And I'm looking forward to seeing the result of those. And we are in the middle of that study. We should be closing that trial toward the middle of next year.
I see. Very, very exciting. Very exciting work. I'm sure we're all interested in how it turns out. I want to thank you both for participating in the podcast and for sharing these exciting results with us. Thank you.
Thank you, Dr. Kressler.
We really appreciate it. Thank you.
Hi, this is Herb Kressel, editor of Radiology, and today I'm delighted to be joined by Dr. Natalia Maximova, who is a physician at the Pediatric Bone Marrow Transplant Unit at the Institute for Maternal and Child Health in Trieste, Italy. Welcome, Dr. Maximova. Thanks so much for joining us.
Thank you for inviting me.
Sure. I note that you're a pediatric oncologist.
That's right.
It's unusual. We have authors that are not radiologists, but to write on gadolinium deposition is quite a tall order. So tell us a little bit about your institute and how you got interested in this problem.
Our institute is one of the biggest pediatric hospitals of this part of Italy, and we are a third-level hospital, meaning that we get the most complicated and the most intense cases. Indeed, we are the only pediatric bone marrow transplant unit in our area. Furthermore, we also have a lot of patients who actually get from abroad, from nearby countries that might not have a pediatric bone marrow transplant program. So we actually see quite a significant number of patients. I would say that we are a middle-sized bone marrow transplant unit for at least European standards.
Sure.
During the years, I happened to deal with pediatric oncology initially, and then I got passionate about bone marrow transplant. So this is pretty much what I do at the moment and have been doing for the past quite a few years.
Now, how did you actually decide to do this study? In your paper, you mentioned that your unit largely switched to MRI to evaluate patients to reduce the radiation exposure. But how did you get involved in looking at gadolinium?
That's correct. Actually, it's a very interesting story. A couple of years ago, we were dealing with a patient who had a bone marrow transplant for sickle cell disease. And when we occasionally happened to do some imaging after the bone marrow transplant, we were surprised because there were obvious important deposits both in the liver and in the kidneys. Now, it's actually quite common for patients who happen to undergo a bone marrow transplant to have significant iron overload, which is mainly due to prior transfusions. And in a patient with sickle cell disease, that was reasonable, but we've never seen anything like that. So the patient eventually had a liver biopsy, also because of bone marrow transplant reasons, primarily graft versus host disease that we were suspecting. And we were actually surprised to find in the liver not only significant amounts of iron, which we expected, but also gadolinium. So we went back into the medical record. We realized that the patient did have MRIs with gadolinium contrast. And we actually got the idea from this case. So we retrospectively decided to evaluate patients for this aspect.
So originally you were just following up on the extensive iron deposition in the liver and kidneys, and as accidentally simultaneously discovered there was also gadolinium there.
Exactly. So we were the first ones who were actually surprised to find something like that.
So just for the people who are listening and watching, what in general, now you wound up reporting retrospectively on 21 patients, I believe, that had gadolinium exposure. And in general, what were the indications for the studies in these patients?
Well, first of all, you have to consider that the reasons for which the patients ended up having a bone marrow transplant were various. Very many of them were children who had a tumor, mainly leukemias, or very often relapsed leukemias, because it's quite uncommon to undergo a bone marrow transplant in first line. Some of the patients were patients who had hematologic disorders, for instance, sickle cells, thalassemia, and so on. And a fraction of patients were the patients who underwent a bone marrow transplant for inborn errors of metabolism, immune deficiency, and this sort of conditions. So also the indication for the MRI was different among the patients. I would say when it comes to pediatric oncology patients, most of them had MRIs either as initial workup, looking for instance, the original disorder, signs of localization of disease. And then very often these patients have febrile neutropenia, and fungal disease is not uncommon. So we perform MRI to actually search for localization of disease. So I would say that's the main indication, yes.
And all of them had their livers examined, is that correct?
All of them had the patients that were included in the study were actually patients who, when it comes to the study group, had one or more gadolinium-based contrast MRIs at least a month prior to the biopsy. Then they had a liver biopsy performed, usually suspecting graft versus host disease. And since one of the other things we looked up was whether chelation therapy was able to somehow influence the gadolinium presence in the liver, we also, all the patients underwent a second liver biopsy once the chelation therapy was concluded.
Yeah, so it's a very unusual and very interesting patient group. Now, you also had a very small control group of individuals that had not received gadolinium, but had, what was different about these? Were their diseases different? Were they imaged with other technologies? What makes this group different or comparable?
Well, exactly. The difference was mainly the indication to the bone marrow transplant. So, which is also the reason why the control group was actually so small. We wished we had more patients that never had a gadolinium-based contrast MRI before, but the truth is that only patients with very, very, very selective diseases, for instance, patients with osteopetrosis, which is a very rare inborn error of metabolism, metabolism in children when you pretty much have to do a bone marrow transplant almost in an emergency setting, so you don't have time to do MRIs or so. Some patients had immune deficiencies, which is also a setting when you're actually moving to a bone marrow transplant in a very small patient very fast. So that's the main difference between the patients from the control and the study group.
So, Dr. Maximova, we had a little problem with the audio, so you've now joined us by telephone.
That's right.
Tell us, what were the key findings of your study? What did you find when you looked at the liver biopsies in these patients before and after treatment?
Well, so I think the most significant findings of our study was that, first of all, in the patients that had a significant iron overload in the liver, they also had the presence of gadolinium in their liver. And there was a positive correlation between the amount of gadolinium we found in the liver and the level of accumulation of iron. And this was seen both at the MRI and also confirmed at the biopsy. There was no correlation between the amount of gadolinium in the liver and the ductopenia. And there was an inverse correlation between the degree of ductopenia and the amount of iron in the liver. I think the other very important finding was that, yes, we did find gadolinium in the liver of our patients who underwent gadolinium MRI and had iron overload. But what is maybe most significant was that when the patient had chelation therapy, with deferoxamine in peculiar, the gadolinium deposits were reversible. So the elimination of iron from their liver also eliminated the gadolinium.
Very, very fascinating. Now, just out of curiosity, did the MR images in these children in areas other than the liver that had all the iron, were there any findings that could be related to gadolinium deposition in the brain, for example? Have you had the opportunity to look at that?
Well, to the best of my knowledge, not being a radiologist, the only area that I am familiar with that a gadolinium might be identified is actually the brain. Mm-hmm. But unfortunately, we weren't able to review the scans in this sense.
I see. So, were you personally surprised that the chelation therapy also reduced the gadolinium, or was that expected?
Well, I would say that nothing was expected actually in the study in a way. So I was first surprised when I found gadolinium in the liver, and then with the chelation therapy, I was surprised, of course, but one thing we hypothesized was that there might be some sort of transmethylation process going on, and that somehow also the chelation therapy could therefore eliminate also the gadolinium. But I think it actually opens definitely new fields for further research, and maybe also pharmacologists or chemists could provide a better explanation, or should come up with some studies that might explain the findings we've seen.
Sure. We would call this a hypothesis-generating study. In many ways, it raises more questions than it provides answers, but they're very interesting questions.
Definitely.
Now, after your article was published online, we received an interesting letter. But one of the questions that I raised that I think our listeners and viewers would be interested in was the possibility that the gadolinium in the biopsy specimens wasn't actually deposited in the liver tissues per se, but was rather in the vessels and related to altered hemodynamics from sinusoidal obstruction, for example. Do you think that was possible?
I honestly think it's quite unlikely because the only reasons, the main causes why these patients might have such situations might be, for instance, sinusoidal obstruction syndrome, which, however, is a very peculiar clinical biochemical and also radiologic condition. Those patients are patients that are very, very sick. It's actually one of the scariest complications of a bone marrow transplant, and having dealt with these patients, I know that they weren't suffering from this condition. The other thing is that by the time the patients had the liver biopsy, the biopsy didn't show any sign of clots or any situations like that. So I actually think it's a good hypothesis, but I think it's highly unlikely that the patients who described in our study were actually, that this hypothesis might explain the gadolinium deposits in our patients.
I see. Now, what's happened since the study? Have you altered your practice pattern in any way, or done anything to follow up on your initial observations?
Honestly, we didn't really change what we usually do, and the reason is actually very simple. When you're dealing with bone marrow transplant, or in general with oncology patients, because one could say, could we use less gadolinium? Could we do, I don't know, MRIs without contrast? The truth is that very often you are forced to do an MRI in a very peculiar setting. For instance, you're trying to rule out a fungal infection or so, and it's definitely not gadolinium we want to save on, because you actually want the radiologist to provide you with a good and certain answer. So that's one thing. The other reason is that we already use pediatric dosages for gadolinium, so I don't think the dosage could anyway be affected. And furthermore, I think it's very important that actually chelation therapy does remove the gadolinium. So I think I don't think it's going to affect a lot what pediatric transplantologists at least do. Maybe it could be something that might affect other fields of pediatrics. I mean, maybe we try to save on X-rays, so we do a lot less CT scans, but maybe in the future we will also consider whether doing so many contrast MRIs with contrast. And when it comes to further studies, I think, as you already said, this is a study that opens the field to many other potential studies, because it raises very many questions. We're talking about a peculiar setting, and we're talking about definitely a small sample size of patients. So we still haven't done anything, but we're definitely considering maybe trying to see if in joining other centers, maybe we might identify superimposable patients, and that we might actually extend the study to a larger scale to see if the findings will be confirmed.
Right. I think it's important to sort of emphasize, as you did, that although we found the gadolinium, and there are other reports of finding gadolinium deposition, it really hasn't related to any disease state, clear symptoms, or any real clinical problems. So this is something that is of concern at this point more theoretically than practically. The other thing we probably ought to mention, because it didn't sort of the agent that was used in this study was gatoteridate, which I think many people will find surprising, since it has a very good safety profile in general. In fact, I think the best safety profiles of the agent that we use. So it's kind of an interesting finding in that regard as well.
Yeah, definitely. I mean, the reason why we use the specific molecule is actually because it's considered to be the most stable, and it's considered to be the safest one. And as a matter of fact, the Italian pharmacology rules actually make it possible to use only this form when it comes to the pediatric patients. So we were also surprised to actually find the deposit, having used such a a safe product. However, all the patients received this specific contrast, and as the study shows, we did find the gadolinium in the liver in the patients with the iron overload.
Sure. Well, Dr. Maximova, I apologize for the technical problems we had during the recording. I want to thank you very much, first for your article, which was very, very stimulating, and for taking the time to share your experience with us personally. Thank you so much for participating.
Thank you. It was a great pleasure to participate.
Thank you. Bye-bye.
Thank you. Bye-bye.